Good afternoon, friends. Before I start, let me wish you a very happy New Year and a prosperous New Year and many more academic adventures and activities in future to come. And be healthy, prosperous, and progress in life. I'm going to talk to you on the stable ischemic heart disease. How is it different from acute coronary syndrome? As a matter of fact, I think many times we use this term, stable ischemic heart disease, very sort of loosely and don't know exactly what we mean by that. Let me give you a little introduction on this. If you go through the literature, you'll find two nomenclatures which are interchangeably used in the US literature on one side and the British literature on the other side. The US literature uses the word stable ischemic heart disease, and if you see the British literature, it uses the word stable coronary heart disease. This is usually the kind of a pattern that you will see in the modern literature. Now, are they same? Perhaps I think what they mean is same, but if you probably do the hair splitting, I think probably it means that stable ischemic heart disease is more of a physiological diagnosis which will indicate ischemia due to coronary artery disease and non-coronary artery disease ischemia. On the other side, the Britishers perhaps wish to sort of localize themselves to ischemia caused by the coronary artery disease. I think this is what it means. Now, how does stable ischemic heart disease differ from the acute coronary syndrome or acute myocardial infarction? First of all, we must know that ischemic heart disease or the stable ischemic heart disease and acute coronary syndrome, they are the products of the same atherosclerosis process. However, the pathophysiology, symptoms, and the clinical presentations, the prognosis and the prognostic indices, and the therapeutic approaches are different in these two subsets of coronary artery disease. Now, to understand this, if I go to the age-old diagram of the atherosclerosis, in which you see a phase 1, a very small, non-critical lesion into the coronary arteries. In the phase 2, it expands. And the worst is when it comes to the phase 3 and phase 4, when there's a rupture of the plaque which occludes the vessel either completely or partially. If it occludes it completely, it causes an acute myocardial infarction. Partially, it causes non-ST elevation myocardial infarction or the unstable angina. Then the thrombus heals, regresses, and there's a flow reestablished, and the patient develops angina pectoris. Because of the collaterals, when even if there is a total occlusion, there is a silent occlusion, and then it gets back into the stable angina pectoris. So in other words, what you see is something which is kind of an ongoing process where the same atherosclerotic process produces the different sites or the different subsets of the obstruction into the coronary artery disease. To explain you this, let me start with one case. Here's a patient who had an acute inferior wall myocardial infarction in 1994, and he was 82 years, mild hypertension, diabetes, and he underwent a stenting with a Pahlajani stent in his mid-right coronary artery. Lately, about a couple of months back, he came with an acute myocardial infarction of 8 hours duration in some place far away from here. He received a 10-active place and then transferred to our center for the further treatment. And you see here, this man has got an atherosclerotic disease, a stent into the mid-segment which is patent. However, at the ostium of the right coronary artery, he has got a tight lesion with calcification, which would indicate that there was a chronic lesion there which ruptured and produced an acute coronary syndrome and acute myocardial infarction. In other words, what I want to say, It's the same process. It's the same pathological disease, but has got a different pathophysiological process. This is again established by the fact that you see this man has got a tight left main artery disease also, which otherwise would have been working like a chronic stable angina in this particular patient. As opposed to this, you see a patient who is a 65 years male who had an anterior wall infarction, again received a 1080 place within 3 hours. You see here, he has got a resolved thrombus, and this thrombus, if it completely resolves or the patient undergoes an angioplasty with a stent, he will be put into the basket of a stable ischemic heart disease. So therefore, if you see what's the exact difference between the two in the pathophysiological process, in one there's a lipid core with a thick fibrous cap. On the other side there's a lipid core with a thin fibrous cap. A thin fibrous cap is responsible for the rupture and producing an acute coronary syndrome. So therefore, for a patient who is a stable coronary artery disease, for him to get into the danger zone, he has to have a low smooth muscle cells, large lipid core, thin fibrous cap, and high content of the macrophages, which will put him into the danger zone. So therefore, to summarize this, what I've said, in the center you have got a stable ischemic heart disease. As unstable angina and myocardial infarction can ultimately get into the stable phase. Otherwise, a patient who is completely asymptomatic due to fatty strix, insignificant lesions, or due to the glogos remodeling, even if the lesion or thrombus, or if the atherosclerotic burden is high, or due to collaterals or silent ischemia, can be totally asymptomatic, totally unrecognized. On the other side, you could have a patient who could have an imbalance between the oxygen demand and supply, which could make him symptomatic. In other words, it is kind of a two-way traffic between all these syndromes where the patient can become stable or can become unstable or develop a myocardial infarction. What protects these patients from developing symptoms is the fact the coronary artery perfusion gets decreased only if there is a reduction in the lumen to about 70%. Less than 70%, or if the pressure drop, what we call as an FFR, is less, is not significant, the patient's blood flow, which is seen on the horizontal axis, is maintained. So therefore, many patients have a stable disease in the form of fatty streaks, or the non-significant lesion less than 70%. They are moving around with the coronary artery disease or atherosclerotic coronary artery disease, but they remain totally asymptomatic. The other phenomenon which helps them is what is called as the glogos remodeling. You see the third kind of a diagram in which you find there is a lesion, there's a lumen in between, there is a thrombus, or there is a atheroburden. And though the atheroburden increases, the vessel diameter expands outside, but the lumen remains same. So the flow is maintained. So though the atheroburden increases, yet for several months and years, the patients can remain totally asymptomatic in this particular case where if there is a glogos phenomenon. Now, what is the difference between the acute coronary syndrome and the stable ischemic heart disease? While the unstable angina or acute coronary syndrome can be risk stratified by the various known factors, risk factors, and as you know in the TIMI score there are 7 possible risk factors, and higher the number of risk factors, worse is the prognosis. You can see if the patient has got 6 to 7 risk factors, the 30-day mortality is close to 40%. But whatever may be the number of risk factor, you can see the mortality even in the lowest possible risk is far more than the patient who has got a chronic stable coronary artery disease. And you look at the data from the TACTIS TIMI 18 trial, that you find that the patients who have got a lower score, their death, myocardial infarction, acute coronary syndrome by 6 months is 11 to 12%. So even the patients who have got a low TIMI score in the acute coronary syndrome, they've got a very grave prognosis. That's how the stable coronary artery disease is, first of all, it's very difficult to risk stratify because there are no known risk stratifying factors for the stable coronary artery disease, whereas for the acute coronary syndrome, there are very well known factors which can risk stratify an acute coronary syndrome. The second thing is the effect of drugs. The patients with a stable coronary artery disease react differently, or their outcomes are different with the different drug therapy. While the aspirin, clopidogrel, and antiplatelet agents are the cornerstone of treatment for the acute coronary syndrome and non-ST elevation myocardial infarction, in patients who have got ischemic heart disease, which is stable, you find that the aspirin, in the absence of prior ischemic events, as seen or reported by the REACH registry, in which there were 13,000 patients who had no prior ischemic event, you will find their all-cause death, myocardial infarction, or stroke was no different from the patients who did not receive aspirin. So therefore, aspirin fails to provide protection to the patients with stable ischemic heart disease if they had no prior ischemic events, as opposed to acute coronary syndrome patients where the antiplatelet drugs are the cornerstone of the treatment. The one thing which one can look at is by coronary angio, and one can risk stratify stable ischemic heart disease by coronary angio. And they have got an excellent prognosis if they have got a single vessel disease, they have got a double vessel disease, they are in a patient with a single vessel disease of 75% or more obstruction, you can see the 5-year survival is 91%, which is really very good because it amounts to 2% a year. So they do far better than the patients who have got an acute coronary syndrome. So therefore, what is the treatment option in these patients? If the antiplatelets in a patient who has got a stable ischemic heart disease and no prior ischemic syndrome. All these years, we have been thinking that the angioplasty perhaps will be the best form of treatment. So I just want to go by this, by saying that what goes up must come down, as was said by Isaac Newton. And if you see, from 1995 to 2003, the trend in the number of angioplasties kept on increasing. And the biggest jolt came in year 2007 when the COURAGE trial was published, and that showed that whether you did at PCI in these patients with stable coronary artery disease or you gave them an optimum medical treatment, there was no difference between the two forms of treatment, and therefore immediately there was a complete drop or significant drop in the number of patients who were subjected to PCI after the year 2007, and it correlated with the year 2007 because that's the time when the COURAGE trial was published. As opposed to this, the drop in the acute coronary syndrome numbers was not so significant. And subsequent to that, if you look at the data which has come from the meta-analysis of 5 trials, which included 5,286 patients, ischemia was diagnosed by stress testing, echo, nuclear, or FFR, and the follow-up was, median follow-up was for 5 years. And you see that death from any cause, non-fatal myocardial infarction, unplanned revascularization, and angina relief. Except for unplanned revascularization, there was no difference between the PCI with the medical therapy or the medical therapy alone, suggesting that these patients, as opposed to the patients with acute coronary syndrome, who are high-risk acute coronary syndrome, where the invasive treatment will be better than the medical therapy, in this group of subset of patients, the medical therapy is good enough, is good enough. So therefore, if you look at the data which has been published in 2007, the current treatment of coronary artery disease, when clubbed together, Still 91% patients are being managed with the medical form of treatment. It's only a small, about 10% of patients who undergo either CABG or a PCI. And therefore, to conclude, the atherosclerosis is the basis of both stable ischemic heart disease and acute coronary syndrome. However, there is a changes in the symptoms and the prognosis between the stable ischemic heart disease and acute coronary syndrome, but it is basically due to pathophysiological process. When the lesion becomes unstable, it develops a necrotic core, it ruptures, produces thrombus, then the whole prognosis and the treatment strategy changes. And generally, in patients with stable ischemic heart disease, the immediate as well as the medium-term prognosis is good. However, to prevent a stable plaque to become unstable, I think that the goals of treatment should be directed to see that we stabilize the plaque or let the plaque remain stable. We passivize the plaque in case it becomes active and direct our energies to the regression of the atherosclerosis. Thank you very much.
Thank you very much, sir. That was a very good beginning to the concepts of the stable ischemic heart disease. We have time for a few questions. Any question or any comments from?
You showed one case of the RCA proximal disease. Earlier it was. So how to say post ACS that this patient is stable or like a decision making whether.
Yeah, you see now this patient came with an acute inferior wall infarction, was given tenecteplase place. You saw a partially, or you can say greatly recanalized vessel, and that's where he needed a stent. That's what was done. Now post thrombolysis and post angioplasty, he had a critical left main disease. That also was tackled because he was 82 years. We tackled after discussing with him, he refused surgery. The left main bifurcation was done with the stenting. Now, following that, if he remains stable for 1 year, and that's what we will call him now, he'll get into the basket of stable ischemic heart disease. He'll continue to remain stable, and he'll be managed with statins, aspirin, clopidogrel, because he has got now 3 or 4 stents. That's how we'll go on. So he'll be sort of a stable, labeled as stable, as long as he goes on for stable for next 1 year's time.
You have shown in your data that the 9%, 7 plus 2% patient with a stable coronary artery disease, they go for PCI and CAB. So what are the particular indication in those 7 or 2% cases where one has to subject them?
You saw the ischemia burden as well as the number of vessels, which I showed the slide. Patients who have got a left main disease, patients who have got a critical triple vessel disease, I think these are the patients who should go for a cabbage. There's another data which has shown that patients who have got 2 important symptoms and the signs. Number 1, patients who have got a severe angina and patients who have got ischemia demonstrable by the stress test, nuclear studies. Combine these 2, if you do an intervention, they do better than the patients who undergo a medical therapy. Again, on this, whether the ischemia is the determining factor or the anatomy is the determining factor, there's another data in which between the 2, if you see the anatomy like left main disease or severe triple vessel disease, these are the patients perhaps who will do better with the medical treatment. So if you combine both, you combine symptoms, the ischemia induction by the various tests, and you demonstrate left main disease or the triple vessel disease, if you combine all 3, these are the patients who should go for surgery or angioplasty.
Dr. Yadav.
Did I hear it correct, sir? You said that for stable ischemic heart disease, non-invasive modalities of investigations are not good for risk stratification, and you will do risk stratification with coronary angiography?
No, I never said that. No.
Yeah, that's what I wanted to know.
No, as a matter of fact, many of these patients may be totally asymptomatic also. Many of these patients.
And what is the role of coronary angiography?
Pardon? In case he has got symptoms, you induce ischemia by the various tests, then of course he has to go for an angiogram. That's what I told him, yes.
Well, my understanding and the ACC guideline 2014, which came and Finn et al. Has published it, they have used categorical word unacceptable ischemic symptoms. And those unacceptable are not unacceptable either to the physician or to the cardiologist. It has to be unacceptable to the patient. So to me and my understanding, honestly, non-invasive modalities of risk stratification are the gold standard. They're given the 3 categories. And in geography, in stable ischemic heart disease, if it's truly stable, unless you have very high provocable ischemia, has virtually no role, unless on non-invasive risk stratification you have a high-risk category.
Correct. I agree with you, because I don't think a patient who has got a chronic stable angina or patient who has stable ischemic heart disease, in him a routine coronary angiography is indicated. No.
Thank you very much, sir.